Hello, today we're going to talk about spirometry. The spirometer measures changes in the lung volume. The max volume of all the airways in an adult is about 5 to 6 liters. Respiratory physiologists have defined a series of volumes and capacities that are easy to measure with simple lab equipment. These values may provide useful insight for clinical assessments. So basically, this is a study of how well you can move air in and out of your lungs. Now, what we would do, we're not in lab, but what a student in my lab would do is we have this setup where you have an airflow transducer, and you can't see it, but inside there is a metal mesh that can track how much air is flowing back and forth through it. And of course, you're breathing through your mouth, not your nose, so we clip it off. Um, and of course, we have a bacteriological filter to keep things sterile. But how it works is you produce a spirogram. You can literally see the volumes going up and down as you breathe in and as you breathe out. And the convention is the way this is set up. When you take a breath out, it goes down, that red line right there. So what you're seeing here in the spirogram, spirometry. Now we basically do this. It's a quick study and measure to see how well your patient can breathe. So this is basically how you read a spirogram. Breathe in, breathe out. So maybe that's just kind of like a normal breath. So usually the procedure is take a few normal breaths. That will be one breath. Here's another breath. Breathe in, breathe out, breathe in, breathe out. Then you would instruct the patient or the subject to take a deep breath in, a max breath in as deep as you can, and then blow it all out as hard as you can and as fast as you can. So super deep breath, blow it all out. So breathe it all the way in and push it all the way out as quick as you can. And then just take a few normal breaths again. Usually it doesn't go down that far, maybe we're like that. And a few normal breaths. Okay, so that deep breath is really showing that subject's capacity and lung volume. And there's a series of volumes and capacities that we like students to know. And of course, you can study them from the table, but since I'm here talking about it, we can kind of go through it on the grease board. For example, the normal quiet breathing is the tidal volume. And so, for example, you would just kind of measure from this top point of a normal breath to this bottom point right there. That would be just a normal breath in, breath out. We call that tidal volume. Normal, quiet breathing. Call number one. TV. I'm just going to use abbreviations here. It's spelled out for you here. And on the slide, I also give you the average volume, maybe about 500 ml, a half liter of air, when you're just sitting there quietly breathing. But then if you kind of measure from, say, for example, this top mark to this top mark, my spirogram word's getting in the way. Say from there to there. So that volume of blood, you take a normal breath in, but then you have some reserve. You can take a deeper breath in all the way up to that top point, all the way in. So anyways, we call that your IRV, your inspiratory reserve volume, okay? And this is a large volume. You can fully inflate your lungs above a normal breath in. And so you have about 2 to 3 liters of reserve volume for a deep inspiration. So if you add the TB plus the IRV, that's your entire inspiratory capacity, or your IC. So pretty much from this bottom point here to this top mark here, number one, these are the capacities in blue, your IC, inspiratory capacity, just the sum of these two things. Then, when you take a normal breath out, you can actually push more out by gasping, right? But that's not very much air, because remember, your lung wall is stuck to your chest wall. But you can push out this amount of volume, and we call it your ERV, your expiratory reserve volume. So basically, from this normal breath out to your maximal breath out, this volume of air right there, called number 2, your ERV. Actually, I should have used red. It's a volume, not a capacity. Let me change it to red. Keeping the volumes red, the capacity is blue. Your ERV. It's about a liter. There's a volume of air that you just can't get out because, again, your lung wall is stuck to your chest wall. The only way you could really get it out is if your lung collapsed. And of course, we don't want that, but we have to account for it. It's a volume of air that's there. It's called your residual volume. So I'll just kind of put another line here from there to there. Say that's the bottom point there. So I'll call this number 4, your RV, your residual volume, the volume air you can't get out of your lung. It can be measured. There are techniques where you can measure it. It's about a liter. Okay. Then you have what's called the functional residual capacity. So I'll use blue. It's a capacity. It's your FRC, but it's basically the ERV plus the RV. So from here, this bottom point, the bottom of a normal breath out, all the way down to the residual volume. From there to there, called number 2, functional residual capacity. So if you think about it, this is all the air in your lung while you're breathing in and out up here, right? But you have this like 2+ liters of air that's in your lung, and it's very important because it has a function. The function is it acts as a huge reservoir for oxygen-rich air, so that as blood permeates and perfuses your lung, there's always oxygen to enter your blood and always CO2 to exit your blood because of this big mixing chamber, okay, that's always filled with fresh air. You breathe in, breathe out, breathe in, breathe out. All of this is fresh air that can be exchanged with pulmonary blood. So that's the function of the functional residual capacity. It keeps your blood gases at a steady state so that your blood gases aren't going up and down with each breath in and out because you have this big reserve. And well, more on that later. For now, just kind of know the FRC is the addition of the RV plus the ERV. Vital capacity. And this is pretty much the number one thing that the technicians look for, that you have a normal vital capacity. So it's basically this top mark here to this bottom mark here, from there all the way to there. Maximal breath in, maximal breath out that you can do in the lab, that you can visibly see and measure by a technician. Number 3, VC, vital capacity, about 3 to 5 liters. There's a range because on average, men values are a little higher because men are a little bit heavier. And so on average, men have a little bit larger lung volume to oxygenate all that tissue. So basically, the bigger and taller you are, the bigger your lung capacity should be. Now, if you want to measure all of it with the RV, that's your total lung capacity. So I'll just kind of go extend this line, this top mark, all the way to this bottom mark. And just get all of it, everything in between, all the things added together. TLC, total lung capacity, 4 to 6 liters. And it's tabled out here too, and you can kind of like review it. And I don't make the numbers match exactly, but just get the gist, the basic idea of what these volumes and capacities are. Now, knowing the normal, we should kind of talk about pathologies that may cause hypoxia. And hypoxia is a lack of oxygen, okay? And this is a great concern for the respiratory system, whose main job is to pick up oxygen from the fresh air you're breathing. And so let's kind of look at the 2 basic categories of disease, which are restrictive, obstructive lung disease. So we got the 2 basic categories of lung disease that encompass most of them, either restrictive or obstructive. Restrictive lung disease, it's the ability of a lung to stretch is the ability of a lung to stretch is compliance. So a lung that is very high compliance, it stretches easily. This is good, easy to inflate. A low compliance lung requires more force from the inspiratory muscles to stretch it. So compliance, good. Low compliance, not so good. Basically, it's difficult to inflate a stiff lung, which is what I say there. You're restricted from inflating it. It's difficult to inflate a stretched lung. Diseases that decrease lung compliance are called restrictive lung diseases. Ventilation is effective because more work must be done, must be expended to stretch a stiff lung. Obstructive lung disease, there's something obstructing the the airflow. Normal breath sounds resemble a quiet whoosh made by flowing air, and we call that normal quiet breathing. But in diseases in which airflow is diminished because of increased airway resistance are obstructive lung diseases. All right, sorry for the interruption. There is an obstruction in obstructive lung disease. Diseases in which airflow is diminished because of increased airway resistance are obstructive lung diseases. When patients forcefully exhale, air whistles through narrowed airways, creating a wheezing sound that can be heard even without a stethoscope. And basically, lungs are easier to inflate, difficult to empty. So that's kind of how I'd summarize the obstructive lung diseases. So it's hard to summarize 2 major classes of lung disease in one sentence, but basically that's usually what you may see. Let's go through some of the specific lung diseases you may come across in your clinical days. Emphysema, considered an obstructive lung disease. I'll just list it under here. It's a destruction of the alveolar wall. So what you end up with is it produces a smaller number of larger alveoli, and that's not a good thing. A larger alveoli has less surface area, so you have less area for gas exchange. Lungs are overly compliant because you have a destruction of the elastic fibers. So again, easy to inflate, difficult to empty. So in this picture, here's like a normal alveolar sac with all these little air pockets, the alveoli, normal gas exchange, poor to rich as gas is exchanged across there. But here, the blood remains deoxygenated because look, you've broken down, you've destroyed the alveolar structure there. So there's less surface area for gas exchange, so blood doesn't become satisfactory. It doesn't become fully oxygenated. Here's a picture of normal lung that we kind of looked at. Here's a picture of emphysema lung at the same magnification. Here's a higher magnification of emphysema lung. And you can see, by just looking at it, it looks terrible. It doesn't have the nice organization of normal lung tissue. Fewer, smaller, larger alveoli, impaired gas exchange, not good. And obstructive lung disease. Fibrotic lung disease is considered a restrictive lung disease. The fibrosis is characterized by development of scar tissue that restricts lung inflation. Thickened respiratory membrane from the extra fibrous deposits. The thickened respiratory membrane, it slows the gas exchange, so the oxygen tension remains low for blood leaving the lung. This loss of lung compliance may decrease alveolar ventilation. So that thickened membrane makes the gas exchange difficult. Fibrotic lung disease. Pulmonary edema. Edema is swelling. It's considered a restrictive lung disease. Basically, this is when fluids accumulate and you increase the diffusion distance so that the oxygen exchange is impaired. So it's considered restrictive because it's difficult to inflate the alveolar sacs when they're surrounded by fluid. It's like if you stuck a balloon and tried to blow it up underwater, it'd be very difficult because you have all that water pressing on it. It's just difficult to inflate. Same kind of principle here. Pulmonary edema. So asthma is the classic obstructive lung disease. Where the obstruction is some bronchospasm that constrict the airway and increases airway resistance, decreasing alveolar ventilation. Now, there are some tests that we can even do in this lab. Well, we're not going to technically do them, but let's just learn about the concept of what you would do in a physiology lab, these pulmonary function tests that students do. And FEV1 is a common one. So FEV1 stands for forced expiratory volume, and the 1 is 1 second. So know that, forced expiratory volume. So what does that mean? How much air can you push out of your lungs in 1 second? Forcefully, not gently. That's gentle. Forcefully would be, I mean, I'm kind of exaggerating, but you get the idea. Because what you want to show is that you should be able to push out 80% of your vital capacity in 1 second. Okay? So basically, just breathe all the way in and push it all the way out as fast, as hard as you can. It's very simple. And if you can push out at least 80% of your vital capacity within a second, that's considered normal. Okay, that's kind of a textbook standard. Sometimes we call the VC, the vital capacity, the FVC for forced vital capacity. So if you ever see FVC, it's interchangeable with VC. And so here's a spirogram. Usually we make the spirogram read so it goes up as you push air out. And how you read this is time 0 is when you start to blow the air out of your lungs. And the reason why it takes several seconds is it takes about that long to push all the air out. You push most of the air out in the first second, and all the rest are just pushing just a smaller and smaller volume, like so that gasping at the end, there's hardly anything coming out, but you measure it all. And we never even consider FEV3 or beyond that. And well, anyways, the top mark is going to be FVC. So the reason why I mention this is, again, that top mark is all you pushed out. So if you push out this much, kind of draw here. Here's 1 second. This top, let's say you push it all out like that. So that top mark, that's your forced vital capacity, whatever it is. Let's say it's 3.4 liters, just to put a number to it. And let's say in 1 second, you pushed out that much. And let's call that your forced expiratory volume 1. That's your FEV1 because that's what you blew out in 1 second. Let's say that's 3.1 liters. Okay, I'm just kind of ballparking it, giving you some typical lab numbers that you would have seen if you were in lab. And if you took a percentage of that, let me do that real quick. All right, so I did the math. I hit the pause button, did the math. But you're just taking a percentage. Percentage is always part divided by the whole, right? That's our part, our FEV1. The whole is all of it that you push out, your FVC. And so divided times by, multiplied by 100, and basically just over 91% normal if that were a true result. And so the reason why I mention this, take a picture of that math real quick. The reason why I mention it is in an obstructive lung disease, you may see an impaired FEV1. You can get it all out, but it takes you longer, so that trace might look different. Here's an example right there. So for obstructive lung disease, you may see a decrease in FEV1, but VC may be normal. It's just, it takes you a long time to get it out. There's an obstruction, so that may be decreased. That's what you see here. Eventually, for obstructive, the blue line, you get it all out. But in that first second, you can't push it all out because of the obstruction. So it's going to be a much lower percentage, much less than 80%. For restrictive, there's no obstruction. So you can get it all out. However, everything's just kind of dampened down, and that's not good. You can't just push a lot out. That means there's a lot of air trapped in your lung for restrictive lung disease. So you may see a decreased VC, decreased TLC. FEV1 may appear normal, but don't be deceived because, well, what matters is these values. If a normal VC is about 3 or 4 and it's about 2, something's wrong there. Okay, should be about 3 or 4. Look at the average numbers there, and basically you can even predict what your patient's vital capacity should be based on gender, based on height and weight. And there are tables you can look at and to see the normative values. And well, anyways, I just wanted to give you an idea of how spirometry um, relates to some kind of patient diagnosis. Okay, that's it for this.